Waalaikumsalam, Dokter.
How are you, all year two students?
Good, Doctor.
All are fine?
Alhamdulillah. Fine, Doctor.
Alhamdulillah. Yes. Bismillah ar-Rahman ar-Rahim. Now we can start our last topic in endocrine pharmacology under the title of antidiabetic drugs. Anti-diabetic drugs. This title may include two main groups. One, parenteral, which is insulin, and the other is oral. This oral nowadays known as oral anti-diabetic drugs. In the past, or since a few years, it was known as oral hypoglycemic drugs. But nowadays, we can say we have oral anti-diabetic drugs, and these oral antidiabetic drugs may contain three important classes. This is new classification. Three important classes known as insulin secretagogues, insulin sensitizers, and the drugs which inhibit the glucose absorption. So again, now I want to change this. This is known as oral hypoglycemic. This oral hypoglycemic may be now equal what is known as insulin secretagogues. So the more sensitive, the more which looks to be newly term to say about treatment of diabetes by oral anti-diabetic drugs and the insulin. Insulin the same, naming, no change, but here we will write what is known as oral anti-diabetic drugs. One of them is oral hypoglycemic, which is the insulin secretagogue. Insulin secretagogue may be known as oral hypoglycemic. Number two, insulin sensitizers. Number three, it will be the drugs which inhibit the absorption of glucose. So this may be our oral antidiabetic drugs. Insulin secretagogues. Two examples, sulfonylureas, the most important, meglitinides, less important, insulin sensitizers, also two examples, biguanides and glitazones. The last is the inhibitors of glucose absorption. The most important is acarbose, less important miglitol. So our main classes, parenteral insulin, oral antidiabetic. This oral antidiabetic will further subdivided into three classes: insulin secretagogues, insulin sensitizers, and inhibitors of glucose absorption. Each time I have one common example, more in use. Sulfonylurea, very old and still updated group sulfonylureas. Meglitinides, this in its use, this common. Insulin sensitizer by guanides commonly used all over the world by guanides. Glitazones less. Inhibitors of glucose absorption, acarbose, and meglitol. Before starting this, we wanted to have an idea about this diabetes. Diabetes can be considered as a simple disease, or it is a group of common metabolic disorders. A simple disease,
Common metabolic.
yes, very similar, maybe in the future to be known as a syndrome, because it is not a single, it is a disease which may affect the whole body. Diabetes may be for a long time. Diabetes need lifestyle in order to control it, not only drugs, but the lifestyle. This diabetes may share the phenotype of hyperglycemia. May share the phenotype of hyperglycemia. The screen shows increased blood glucose, hyperglycemia. Several types of diabetes mellitus exist and are caused by a complex interaction of genetics and environmental factors. When I am asked about the cause, I cannot determine definitive cause for this diabetes, but may have genetic basis, yes, may have environmental factors which affect the body, yes, maybe viral. Some authors more than 20 years ago speak about the possibility of something like this, but till now not well-defined etiology, but genetic factor, okay, environmental factors, okay, like this. We can say that factors which contribute to this hyperglycemia in the body may include insulin secretion, which is reduced, which is less than normal, which is less than the need of the body. So, reduced insulin secretion may be atrophy in islet of Langerhans in type 1, maybe something like this. Diminished secretion in type 2, yes. Also decreased glucose utilization. Also decreased glucose utilization. That is to say, glucose in the blood, big amount, but the tissues cannot take its use, cannot take a good amount. So still hyperglycemia without good glucose utilization by tissues. Glucose cannot enter easily the cells. And also may be increased glucose production, gluconeogenesis. So many metabolic disorders may be present. One of them, decreased insulin secretion, decreased glucose utilization due to absence of insulin, and maybe increased glucose production. This is simple presentation of factors which may be contributing to the hyperglycemia. Why hyperglycemia? In order to have an idea about the risk, the importance of this disease all over the world, we can say in United States, for example, diabetes can be considered as the cause of end-stage renal disease. Diabetes may be the cause of end-stage renal disease. As to say, many patients have renal troubles, and these renal troubles may be the cause of mortality. But the start was due to diabetes or diabetic nephropathy. Also, in USA, in the United States, the big percent of surgery, including amputations of lower extremities, which is non-traumatic, not related to accidents, is due to diabetes. Also regarding the ophthalmology, big number of adult blindness is due to diabetes. So this diabetes is a leading cause for three main problems: renal disease, amputations, adult blindness due to diabetic retinopathy. It also predisposed to cardiovascular diseases. So some authors may speak about this disease. This disease better to be studied not in endocrine medicine, endocrinology, but in vascular. It is a disease which affects the blood vessels and so may be considered as a vascular disease. Finally, we can consider that this disease may be a leading cause of morbidity and mortality in the future. So this is the risk of this diabetes. And so this diabetes is very important to deal with it. We can consider now for long duration, the authors consider only type 1 and type 2. For long duration, authors consider diabetes in its classification, two categories, type 1 and type 2. Recently, we can add type 3 and the type 4. Type 3 and the type 4. Type 1, which is insulin-dependent diabetes, IDDM, patient cannot be treated by something other than insulin, only insulin. Without insulin, no life. Type 2, non-insulin dependent diabetes, many of them are obese, but type 1 not obese. What is the added type 3 and type 4? Type 4 gestational. Gestational, this is female, pregnant, and have diabetes for the first time during pregnancy. This is known as type 4 or gestational diabetes. What about diabetes after finishing, after delivery? May disappear, like hypertension also, maybe during pregnancy, but after delivery, no hypertension. Diabetes may be the same, only during pregnancy. Why? Due to many changes in the metabolism of the body with the process of pregnancy. What about this type 3? Type 3 may be diabetes related to factors or multiple other specific factors or causes of hyperglycemia, but these causes non-pancreatic. That's to say, when we speak about the main factors contributing to hyperglycemia, we speak about diminished insulin production, diminished glucose utilization by the tissue. Here we speak about something related to pancreas, like for example, drug therapy, drugs that may lead to diabetes, hyperglycemia. This can be considered as type 3. This is some differentiation between type 1 and type 2. Regarding the age of onset, usually less than 30 years, maybe early childhood, 5 years, 4 years, like this, may be detected. Sometimes may be delayed up to 20 years or more, like this. So the onset in general may be less than 30 years. In type 2, more than 30 years, maybe more than 40, 45, like this. Insulin deficiency, severe, may lead to atrophy of the islets of Langerhans. So severe insulin deficiency. Here in type 2, this insulin deficiency may be moderate deficiency, variable. So we depend on the treatment of this type 2 to stimulate this pancreas, to increase its secretion from insulin, stimulate, make it more sensitive So our groups include insulin secretagogues and insulin sensitizers. Regarding the ketosis as a biochemical process, may be marked in type 1 and may end in coma. In type 2, may be absent. The isolated cell antibodies, yes, there is. If we search for antibodies for isolate of Langerhans, we can find in type 1, but not in type 2. The body weight here, usually, type 1 may be thin, not obese. Type 2, many cases more than or about 85%, maybe 85% obese. The treatment with insulin mandatory in type 1, always necessary, mandatory. But in type 2, if there is failure of the oral antidiabetic drugs like oral hypoglycemic, insulin secretagogue, insulin sensitizer, also there are new drugs other than this oral antidiabetic. If there is failure for this oral, we can resort to insulin. Also in emergency, we need insulin in type 2. This is in general the symptoms and the method to diagnose easily the diabetes. The symptoms include polyuria, nocturia, polydipsia, first, polyphagia, and weight loss. You find your patient eat more, but sometimes losing weight. This patient sometimes may be detected in an attack with severe increase in the blood glucose with ketoacidosis. Maybe the presentation. Sometimes the patient have little symptoms regarding polyuria, polydipsia, polyphagia, but still hyperglycemic without like hypertension, maybe for many years without symptoms. Here also may not find these typical symptoms and accidentally or without these symptoms, you may find severe attack of hyperglycemia. Even the patient may go into coma, hyperglycemic coma. Maybe the discovery of this type 2. The diagnosis, of diabetes may be simply by doing fasting blood glucose. If this fasting blood glucose, patient may be fasting for 6 hours and take blood sample. If it is more than 126 milligram percent on at least 2 separate occasions, I can diagnose this case of diabetes, not one exam or one investigation or one test, more than one test, at least 2 separate occasions. Also, we can resort to something like oral glucose tolerance test. This may include many blood samples, for example, after intake of glucose, after half hour, after 1 hour, after about 2 hours, like this. It is like a curve and may help or support the diagnosis of diabetes. In order to summarize, the management or treatment of diabetes in general, we can say diet, maybe alone, maybe if this case is borderline, or the blood glucose start to be more than 180, 200, for example, and there is a strict diet regime, good lifestyle may allow the patient to have or to be euglycemic? Yes, maybe. Maybe. So sometimes diet may control. Number two, these oral anti-diabetic drugs in addition to diet. Number three, the failure or ineffectiveness of oral antidiabetic drugs. We can use insulin also plus diet. So almost always you must speak about diet. What about the importance of diet? This diet can control this diabetes if we make focusing on the total caloric intake, and we make good distribution for the diet composition. Just to say, basic principles regarding the diet include total caloric intake and dietary composition. Number one, I must determine as a physician what about the total caloric intake needed for this patient. Not all the patients the same. Suppose now we have one officer or one like student. Almost always he is sitting in his office. And another one, worker, almost always carry heavy things, go, come back through the whole day, not to sit on an office. So this is different jobs. There is different physical activities. This man which is worker may need higher calories, but the other who is 24 hours sitting, no much physical activity, need less caloric intake. So this total caloric intake depend on factors. The most important is this physical activity, the age, and the weight. I must consider all these factors in order to say that this man is a worker and may need 3,000 calories per day. This man is one like a student the whole day in his office. No much physical activity, may only 2,000 plus calories. So this is number one. Who can determine this? This physician, which is which have good experience, those who has a job to be dietetic, also can determine this total caloric intake. Weight reduction by caloric restriction is advised or advisable for obese type 2 diabetic, and they can result in control of hyperglycemia. So we will find a drug with many benefits regarding its use in diabetes. It is biguanide. Biguanide may be used by all obese patients. Biguanide, not hypoglycemic, it may be euglycemic only, but have good advantage for those patients who are obese, but contraindicated not to be used by type 1 who are tend to be thin and not obese. So weight reduction very important if my patient is obese only. This is in type 2. Patient with type 1, very rare to be obese. Not like type 2, which about 85% obese. Very important point when you speak about the management of diabetes in children Be aware about the process of growth and development. Allow this child to grow properly, not to deal with diabetes and to allow this child to be stunted. No. So again, if I want to speak about diet, I must know two important points. Total caloric intake, how to measure. This can be by experienced physician or dietetic. And we can speak about the dietary composition. The dietary composition, the basic are carbohydrate, fats, and the protein. In general, suppose my patient, worker, heavy worker, and need 3,000 calories or more by day. This 3,000 calorie can be given as carbohydrates to allow him to have good calories. I want your answer.
No, doctor.
Can or cannot?
Cannot, doctor.
Cannot. Yes. What to do?
Balanced diet. You cannot give all the calories in the form of carbohydrate because our body needs more than carbohydrate. And then the other thing is because it will cause hyperglycemic condition.
Yes. So I must distribute and have balanced diet. Carbohydrate, fat, protein, if they are equal 100% as a total, I can allow my patient to take about 50% carbohydrate to give him good amount of calories. 50% will be carbohydrate. About 30% or less fats, not more than that. About 20% will be protein. So distribution between carbohydrate, fat, and protein is essential to have a balanced diet and to allow this patient to take or to to make the advantage of each diet composition, not to give him only one type in big amount like carbohydrate. This type of diet is also have many benefits. What is known as dietary fiber. Dietary fiber. Dietary fiber means plant component which cannot easily digested. That's to say, indigestible. Indigestible dietary fibers. These dietary fibers may be soluble or insoluble fibers. Soluble fibers like gums and pectin. Pectins present where and the gums may be in the beans, fruits, leafy vegetables. I almost always advise my patient to take good amount of these vegetables, fruits, beans due to this content of soluble fibers. Insoluble like what? Like cellulose present in bran. Cellulose that is found in bran. Even sometimes in some countries, I may find this bran in the form of tablets like this instead of natural component related to plants. I may found the formulation in some countries formed of bran. Bran have many advantages. What about the importance of these fibers? What about the role of this fiber regarding to the hyperglycemia? Who have an idea about these fibers and its role?
Um, wait, I'm trying to remember. It's related to, I think we have learned it in nutrition. Guys, do you guys remember about it? The term for it. Glycemic index. Glucose index.
These fibers may affect glucose absorption.
Yes.
Yes, doctor.
Yes, this is the main advantage. The glucose absorption will be delayed, will be slow. So the tendency for hyperglycemia will diminish. Also, for the hyperlipidemia may diminish. So something like bran or these soluble fibers may have this good advantage. Almost always, I advise my patient to take more vegetables, more fruits, but not fruits like
Durian.
different types of fruits which contain big amount of sugar, like grapes, contain big amount.
Durian,
This
doctor.
is not advisable. But other fruits like banana, like orange, many of them are good because they contain soluble fibers which delays absorption of glucose. Also, this can be used in the process of allowing the weight reduction. This bran in GIT pharmacology, you can know something like this bran because it may give the patient what is known as sense of fullness. Sense of fullness. That's to say, he is not hungry. He is satisfied now. He has a sense of fullness, cannot eat more. Bran may do something like this. So this bran can be used in obesity? Yes. Can suppress appetite? Yes. These other values for something like these fibers. Also, when we speak about diet, we must know that, especially in cases of insulin, the timing and the size of meals are very important. As to say, when my patient receives insulin, I cannot ask this patient to take insulin in the morning and go to work without taking breakfast. What will be the catastrophe if he take insulin and go to his work? He will do activities, no breakfast. What can occur?
Hypoglycemia.
Hypoglycemia, yes. Another situation, this patient will take insulin at night and go to sleep without eating. What can occur?
Same hypoglycemia.
Hypoglycemia during,
In the morning,
I speak about at night. At night, he will take insulin and go to bed.
The middle of the night, doctor.
What may be the risk?
Hypoglycemia also.
sleeping.
I
During
need
sleeping.
higher voice.
During sleeping, doctor.
What?
During sleep.
Again?
Hypoglycemia during sleeping.
Yes. What is the risk of hypoglycemia during sleep? What's the risk?
Comma?
What is the risk if hypoglycemia occur during sleep?
Death.
May lead to death. Yes. Because if it is in the morning, he will be sweaty. You know that he is hypoglycemic. He can take any something sugary or sweety, and this may be easily managed if he is awoken. But if this attack of hypoglycemia occurred during sleep, he cannot ask for something like this. He may go into coma and may be fatal. So sometimes we prohibit this dose, which may be at night sometimes. If it is taken, dose of insulin at night, I must ask him to eat well and not to go to sleep directly after taking his insulin. So, my advice, take the insulin in the morning and the diet must be ready within half hour. You must take your breakfast within half hour. So, no insulin in the morning without feeding. Breakfast should be eaten within 1/2 hour after the morning insulin dose. This is also important for regulation of diet. So, diabetes is a disease which in high need for good lifestyle. The total caloric intake is distributed over three main meals and three snacks. In some countries, especially in Middle East, many Arab countries only depend on three main meals, maybe big meals, no snacks. This is not good. Better to distribute over three main meals and three snacks, breakfast and mid-morning snack.